Good afternoon, everyone. I am James Hines, the Associate Director of the Ethics Centre. On behalf of the faculty and staff of the Ethics Centre, I want to welcome you to our annual Weinberger Vermut Genetic Ethics Lecture. Before introducing our speaker, let me take this opportunity to renew once again the Centre's sincere gratitude to Tom and Leslie Weinberger, who so generously sponsored this annual event and who have unstintingly supported the Ethics Centre in its mission since its inception. So once again, Tom, and most sincerely on behalf, and Leslie, on behalf of all of us at the Centre, thank you for everything you do for us. It is both my privilege and my pleasure to introduce this year's speaker, the internationally renowned philosopher and bioethicist, Françoise Baylis, who will speak to us today about the ethics of human genome editing. Dr. Baylis is Distinguished Research Professor Emerita at Dalhousie University, Canada. She is the author of Altered Inheritance, CRISPR, and the Ethics of Human Genome Editing, which won the 2020 Prose Award in Clinical Medicine. Dr. Baylis was a member of the planning committee for the first and third international summits on gene editing in 2015 and 2023, respectively, a member of the World Health Organization Expert Advisory Committee on developing global standards for governance and oversight of human genome editing between 2019 and 2021, and a member of WHO working groups on a global governance framework for the responsible use of the life sciences. She is a member of the governing board of the International Science Council and vice chair of its Committee for Freedom and Responsibility in Science. Dr. Baylis is a member of the Order of Canada and the Order of Nova Scotia, as well as an elected fellow of the Royal Society of Canada and the International Science Council. Dr. Baylis is the recipient of numerous awards and accolades, including the 2022 Killam Prize in Humanities, and most recently, the 2023 Canada Council for the Arts Molson Prize in Humanities, Canada's most distinguished awards for humanities scholars. At the end of her lecture, there will be opportunities to put questions to Dr. Baylis. Given the virtual format that we are using, can I ask that you put your questions into the chat, and those questions will then be asked on your behalf by our senior fellow, Dr. Dylan Manson. So, Dr. Baylis, it is truly my privilege to invite you to give the 2023 Weinberger Vermut Genetic Ethics Lecture.
Thank you. I'm going to share my screen now. Hopefully this will work. So let me start by thanking you for that very warm welcome, and more importantly, for the opportunity to share some of my ideas about a topic that I think is actually critically important. And part of what I'm going to try to do today is not only share with you some of what I think are the key ethical issues, but try to put it in a relatively recent political and policy context. Because it's not just an academic exercise to sort of figure out what do we think is important, but really how do we actually action those ideas? How do we bring them into policy? So the first thing I want to do in terms of advancing this is just to make sure that we're using the same terms, because in fact, the terminology in this domain has changed in the last 5 to 10 years, depending on how you count. So when we're talking about somatic genome editing, which I will do in the second part of the talk, we're talking about the manipulation of body cells other than the reproductive cells, so any of the tissues in the body. Germline genome editing is really when we're working with the gametes or with the precursors to the gametes or the early human embryo. The idea, though, is that this research in this area is not necessarily for reproductive purposes. And so that's when we've introduced the distinction about heritable genome editing, where you're doing the same kind of work in the germline, but the intention is, in fact, to move towards reproduction. One of the reasons I wanted to say this at the very beginning is that if you read in this domain over the last 10 years, you will actually see that transition happens. And there's a period about 2 or 3 years where people are using the language a little bit interchangeably. So they'll be talking about germline genome editing when they actually mean heritable genome editing. And the ethical issues in those domains are different. And so it really was important that we actually get that parsed. But I want to name this because, as I say, there'll be times when the text might say germline genome editing, but the concept they're working with is heritable, and they're worried about the inheritance of particular traits. So let me talk very quickly then about germline human genome editing. And from my point of view, this story actually starts in 2015. It starts in 2015 with this paper that's published in Protein and Cell. And this work is important. Why? Because it's the first time that we actually have a publication saying that the human embryo has been manipulated in the lab in the context of a genome editing project. Now, what's particularly important about this project is that this work is done in non-viable embryos, in pronuclear embryos, ultimately tissue that would not have been able to become one of us, right? Not a viable embryo, and also with no intention of reproduction. So there's in fact no transfer that's happening to a human being. This is work in the lab. Now, I want you to pay attention to the date. This article is published in April of 2015. Now, the interesting thing is that in terms of history, the science appears appears after the ethical commentary. And the ethical commentary, look at how proximate it is to the science paper. And we had the first paper coming out in March, the second paper coming out in April. They're in our two high impact journals, Nature and Science, and they're in fact giving a very different message. One of them is saying clearly, very loudly, do not do work in the human germline. And a big part of the concern there is the spillover effect it might have on somatic genome editing. So there's the perspective that it's really important that we be able to develop somatic treatments for patients, and that this kind of far-reaching work meddling with the germline will actually harm that project. On the other hand, you have another group of scientists saying more clearly, no, we actually need to go forward in this area. We just need to be careful about how we do that. And in this context, it means actually to pay attention to some of the ethical issues. But what I think becomes important is that we learn from the author of the science paper that his paper had in fact been submitted to both Nature and Science and was in fact rejected on ethical grounds. Now, the journals themselves have not commented on that, but that's information available to us from the author. And so for me, that raises some very interesting questions about what we choose to publish or not. And it comes back to some of the other work that I do around the responsible use of science, freedom and responsibility for the scientific community, and what happens here. Now, because all of this happens in the spring of 2015, you get the National Academy of Science and Engineering and Medicine, NASEM, that says we need to address this issue. It's a high priority. And we then have in December the first International Summit on Human Genome Editing. What you see in the picture is members of the planning committee. The chair of the committee is David Baltimore. You can probably recognize a number of eminent scientists, including, for example, right in the center beside me, Jennifer Doudna. On the other side of me, Robin Lovell-Badge, Eric Lander, and I could go on. What I've put on the slide is text that I have excerpted from the closing statement that was drafted by the planning committee. And I'm offering you now the comment that's in the category of germline genome editing, because at this point in 2015, that's the only distinction we're making. We're making a distinction between somatic and germline. But you'll notice that the research that's been published is germline research. It's work done only in the lab. The concerns are taking that research out of the lab and moving it into a reproductive project. So with respect to germline genome editing, what you see is that the committee comes up with what I think is actually an amazingly simple and robust ethics framework. It's simple. Why? Because it only has two elements. And anybody who does work in ethics will tell you there's not a lot of frameworks with two elements. It's robust and it's challenging because nobody actually knows what those elements mean. And I say that as a person that participated in crafting that text. So what does it say? It says you have to meet standards of safety and efficacy, and you have to have broad societal consensus. Now, safety and efficacy might seem like it's pretty straightforward, but safe according to whom? And what's the standard for safety? Because it's never going to be 100%. So what's safe enough? What's efficacious enough? Well, that's a value-laden question. And you'd have to actually do a lot of work in terms of consultation and thinking and policy making to understand where are you going to draw the line? When are you going to say it's good to go, if ever? And then this notion of broad societal consensus, it's really the first time that this gets moved into the policy discussion and debate. And it's very much about trying to create a space for public discussion. It's about saying this isn't a decision that should be left to the scientific community alone. Why? Because the question, the issue is far too important. Now, the interesting thing is that since then, there's been ongoing work and debate about this issue of broad societal consensus. There hasn't been, I think, equivalent work around safety and efficacy at the conceptual level. There's a lot of work happening in the scientific realm, but what do we think about it at a conceptual level? What's safe enough? What's efficacious enough? Who gets to decide? That debate, however, we have had with respect to broad societal consensus. And what I've put up here for you is basically the summary of the work that I've been doing in this domain. So I've published a number of different articles with a lot of different kinds of content in terms of standards. But at the end of the day, in summary, what I'm saying, it's about unity, not unanimity. It's not about majority rule. It's not about everybody agrees. What it is about getting all the ideas on the table. So we keep having that conversation until we're confident that all perspectives are there, that people feel respected, that their perspective has been heard and listened to. It doesn't mean that everybody's perspective can be endorsed, right? But the consensus building, what's really important about that is it's about a process. And the reality of it is when I take pushback and people argue, okay, that's pie in the sky, we're never going to reach consensus. I'm willing to say, as a person who's advocating for this, I'm willing to say, it's possible I'm wrong. It's possible we will never achieve any kind of broad societal consensus. But I will say to you, we will be better off for having tried, because we will in fact move people along with us by showing them respect and listening to their diverse points of view and engaging with them. And anybody who's in the business of knowledge production knows ultimately that it's this dialectical process of push and pull and exchange of ideas that helps us in this realm. So I remain deeply committed to the idea of broad societal consensus. And if you're ever interested, you can easily find some of my writings on that, where I actually try to spell out what are the key elements of that. In the interest of time, I'm not going to do that today. Now, let me quickly transition from germline, which is the language that we're using around 2015, to what we now say more clearly is about heritable human genome editing, because many people, if they are supportive of research in the human embryo, and I acknowledge that some people are not, but people who are supportive of research in the human embryo are prepared to say that if this is tissue available for research, it's available for genome editing research. And if it's not for the purpose of reproduction, some people will argue that it's not controversial because it would be serving a therapeutic goal. So for example, it might help to improve in vitro fertilization. It might help our understanding of miscarriage. And so there's a way in which that now gets framed such that for some, if it's restricted to research in the lab, the ethical issues are seen to be different from those that are of concern when we're explicitly talking about heritable human genome editing. Now, In this case, we fast forward to 2018, which is actually the time of the second International Summit on Human Genome Editing. And just in the interest of transparency, I was a member of the first planning committee. I was not a member of the second planning committee. And here you see Zhang He, who has since become quite infamous as the scientist who literally days before the second summit is to start announces to the world that he has in fact used the technology to pursue a reproductive project. It's in pursuit of trying to modify these embryos such that they would be resistant to HIV infection, and that he has initiated a pregnancy. At the time, he announces the birth of Lulu and Nana. These are pseudonyms. You can imagine that in many ways this kind of hijacks the summit, because no matter what else they might have thought was going to be the subject matter, this kind of overtakes the conversation. Now, what I've put before you here is in fact the concluding statement from the planning committee of the second international summit in Hong Kong. What I want to draw to your attention is several things. The first is to say that at the time, so prior to the meeting happening, but post the announcement that the children had been born, a number of people, including David Baltimore, actually used the language from the final report coming out of 2015 to say that this was inappropriate, it was premature, that Zhang He was a rogue scientist, and partly they relied on the content of the closing statement to say safety and efficacy had not been shown and that there was not broad societal consensus. Other scientists said the same thing, including, for example, Feng Zhang. But when it comes to actually crafting the text at the end of the meeting, there's no reference to either of those concepts. So what we hear now is a statement that's actually quite interesting. It says explicitly, it could become acceptable in the future. And what we need is a rigorous, responsible translational pathway towards such trials. Now, think about the overlap between that language of the rigorous, responsible translational pathway and the call in that 2015 paper that I put up for you, right? So you've got to then go back and say, who are the authors of that paper? How many of them are on this committee? The other thing that I think is really important to pay attention to is you have a dramatic shift. Before, in 2015, the statement is it's irresponsible to go forward with this research unless and until you've got safety and efficacy and broad societal consensus. Now, that's the perspective in response to science done in the lab with non-viable embryos. 3 years later, we're out of the lab. We've got babies created. These were with viable embryos. And now we're saying it could be acceptable in the future. Well, you should be having whiplash. You should be asking, wow, what happened in the science in 3 years that we've gone from it would be irresponsible to it could become acceptable in the future? The thing that's important to pay attention to in this context is it's a group of senior scientists, lawyers, ethicists, policymakers. This work doesn't have any legal standing, but you are setting the tone and the direction for discussion and debate. So I want you to hold on to this shift that we've now seen within a 3-year period. So one of the things that becomes very interesting for me, partly because I'm still doing my work and research and writing on this notion of broad societal consensus and thinking that that's a standard that needs to be met, is in the work done by the committee coming out of the 2018 summit, they talk about the elements of this rigorous, responsible pathway forward. There are 5 of them. And in the context of this talk, I'm only going to focus on one: compelling medical need. And this is an important thing because a lot of the science that we do today is motivated, at least in the realm of health, is motivated by trying to develop therapeutic interventions for patients who are suffering. And we think that that's an important goal and objective to pursue. And so that gets imported into this area of science of heritable human genome editing to say there has to be a compelling medical need. So I think it's really interesting to interrogate that. What does that mean? What would be compelling in this arena? Well, The examples that are typically given are of couples who would like to have a genetically related child, but who cannot do so and at the same time hope to have a healthy child. In other words, if they use their own gametes, the expectation is that their child would have a genetic condition for which there's a known risk profile. Now, the important thing to appreciate here is in other contexts, the argument has been made, there are alternatives available. You could, for example, get pregnant and elect to have a termination of pregnancy in the event that the child or the fetus would be afflicted. Or you could use donor gametes. Or you could get pregnant and use prenatal testing. The list goes on in terms of alternatives. But the point being made is that that might work for some people when there's a small or even a high probability that the offspring would be afflicted with the disease, but that there are a few couples in the world where there is no option to have both a genetically related and a healthy child. This is true. Is this a compelling medical need? I have argued, and people disagree with me, that a desire to have children is a want. It may be a very important want. If you're not able to satisfy that want, it may be extremely painful, but it is a want. It is not a need. And for me, it also distorts the importance of family, and it also sets us back in terms of so much progress we've made in terms of understanding what's important about families. We have done work to validate that families come in multiple shapes, sizes, orientations. We embrace children who are adopted. We embrace children who are part of blended families. We embrace children who are born of donor gametes. And all of a sudden, with this technology, we're saying, no, what's really, really important here is that you have a genetic tie. That's what matters. As opposed to you have a child that you want to bring up into the world and that you want to care for. For me, parenting is about responsibilities. It's not about rights. I want to make the point very strongly by presenting you with this additional data. I'm just taking the example of cystic fibrosis. I'm not going to take you through the details. I'm going to ask you to look at the last line. In the United States, this technology might be used once every 15 years. Hardly a compelling medical need. And I say that really strongly. Why? Because I believe that in the realm of research, there are opportunity costs. If we use the time and talent of our researchers and our research dollars to do this, what are we not doing? And I think we need to pay attention to that. I have a lot more that I could say about it, but I want you to take home the idea that if you believe you need to have a compelling medical need to move forward, do you think this technology can meet that in a context where you are not treating an individual who exists and is afflicted with any kind of genetic condition? You're creating a being that doesn't exist and doesn't have to exist. Is that a compelling medical need? It can only be that if you're willing to acknowledge or argue for the belief that parents need to have children, or prospective parents, I should say, that people who wish to be parents need to have children. I think that's a contested matter about which we can have debate and discussion. One of the things that happens after the 2018 summit is that several people who were authors of the 2015 statement got together and then went out to join our work with that of some of the scientists involved and published an article in Nature called Adopt a Moratorium on Heritable Human Genome Editing. The people who signed on to this, Eric Lander was the first author, basically were saying, we're still committed to the idea of broad societal consensus, and we haven't done that work. And we can't do that work if babies are going to start popping up. I mean, you can't have a discussion to try to reach a broad societal consensus if the science is just continuing barreling along. And in that context, we say, we're not saying at this point that we're saying there should be a ban. We're distinguishing a ban from a moratorium. We're saying we're asking for time to try to meet the standards that we had put forward. as I said, with particular emphasis on the notion of broad societal consensus. Now, this is before we have the Nobel Prizes awarded to Emmanuelle Charpentier and Jennifer Doudna. And the other person at the time who was also touted as a possible recipient of the prize was Feng Zhang. We approached all three scientists to sign on to this moratorium. Emmanuelle Charpentier did, Feng Zhang did, Deborah Doudna did not. And it's a choice. And so I think it's really interesting to think again about the politics and the policy surrounding our ethical discussions and debates about next steps and moving forward. In this period, I've also started working on my book that you heard about, Altered Inheritance. And in that context, it comes out in the September of 2019, just before the pandemic. And what I try to do there, in and amongst a number of things, is to actually have a discrete section on what are the potential harms of this technology. And I want to say really clearly, that focus is a large part of my work, no matter what the substantive issue is. Why? Because when we look at innovation, when we look at new technologies, whether it's artificial intelligence, whether it's xenotransplantation, whether it's vaccine technology, we can see the potential benefits. That's why we're racing after this technology. We know that there's the potential to do good. And I see a lot of my work as saying, that's great, but can we just stop for a minute and look around and see who might be harmed? And we need to pay attention to them. And they may not be the majority, but that doesn't mean that we get to just disregard their needs, their interests. So one of the first groups that I look at is harms to women. And one of the things that I try to emphasize is all the focus is on the human embryo. But if you're actually seriously talking about heritable human genome editing, you need women. You need women to get the raw material, to get the eggs. And I say that not in the context that we don't also need gametes from the male, but it's much harder and it's much more onerous. And there are greater potential harms to women in getting access to their eggs. But more importantly, you have to involve them in the reproductive project because you're going to transfer this genetically modified embryo to the woman. And she's going to bear consequences. Might she be approached and told, look, we've actually decided that there's, or we've not decided, we've learned that there are serious potential harms to the developing fetus, and we recommend / we require that you have a termination of pregnancy? Could that happen? I could imagine. Or alternatively, maybe the pregnancy continues and a child is born, and then we learn that the child is compromised in some way. Who's going to bear the burden of care and conscience for that child? Or alternatively, they parent this child and everything looks fine until that child goes off to have children, and then a problem occurs. One of the things that's really important in this space is to recognize this is not merely research on tissue. It's research involving arguably both the male and the female partner who wish to parent, if it's in the context of a heterosexual relationship. But at the very least, it's always going to involve potential harms to women. And they have been erased in this discussion. The next thing, which I think is really important, and this is when I do broaden it beyond just the female partner, is to say that there are harms to prospective parents. And in one case, I think you're looking at a situation whereby they may not be completely aware of, understanding, appreciating the unintended, unwanted, potential harmful consequences that they would somehow perhaps perceive as different because they might have been an outcome of choices that they've made, not an outcome of chance. And I think that that matters if you have a poor outcome. And I think one of the things we also should think about is the potential social pressure, not today when it's sort of a rarefied technology, but that was, for example, once true with respect to prenatal testing, whether it was amniocentesis, whether it was chorionic villus sampling, et cetera. There was a time when this was a new technology. But now it's actually a technology that women are expected to avail themselves of. And if they don't, and there's an unhappy outcome, there's a certain amount of responsibility or blame attributed to somebody for a choice they made when there were other options available to them. And so it's an interesting thing to think about this, not merely in the context of avoiding disease, but in the very distant future, one could imagine, in the context of actually choosing certain kinds of enhancements. Moving along, there's potential harms to future children in terms of what might happen in terms of their health. There's also the possibility of multi-generational harm should they go on to reproduce, and that the potential harms or untoward consequences don't actually appear for the first generation, but later on. And I think one of the things that's really important to appreciate is what happens if you're not just choosing against particular traits, but you're actually choosing for particular traits. And I do think that this is one of the things that has been of great concern to various communities of social activists and civil society, worried about questions in terms of disrespect for persons with disabilities, a failure to take into consideration their views and perspectives, but also this kind of cavalier embrace of a future in which we're building humans to someone's idea of what the ideal human is. And so in this context, I and others have talked about this in terms of a new kind of techno-eugenics. And what does that mean? What does that look like? And who bears the consequences? And that obviously takes me really closely into harms to society if we actually go down this path and end up cleaving, if you will, the world into the haves and the have-nots. There's work done by Lee Silver where he talks about the valids and the invalids, and the play on words for the invalids. The idea that, in fact, what could happen if you really move in this direction of techno-eugenics is you actually will have a situation whereby those who are privileged will now take that privilege and entrench it in their DNA. What kind of world are we building? One of the things, again, in the work that I do generally, is I try to say to people, it's important to think about the future because there are forks in the road. And we don't have much in our history that says if we realize we've made a mistake that we just turn around and go back. No, we just confront a new fork and we keep going. And so it's really important to think about the future, to exercise the moral imagination so we don't wake up one day and find ourselves in a place where we actually don't want to be. It's not the kind of world we had in mind. And I think the kinds of technologies we develop and the ways in which they get absorbed into social practice build the world in which we live. The last thing I allude to very briefly is harms to the gene pool. And in that context, people take it in both directions to say whether you're increasing or decreasing diversity, one could imagine certain kinds of untoward consequences. Well, at the end of 2019, one of the things that happens is we have Zhang He, who's the scientist who's done this work, who was originally lauded by Chinese media. Within days, it gets turned around and he's referred to as the rogue scientist. In my own work, I've actually contested this description of Zhang He. I don't actually think he was a rogue scientist at all. I think he did exactly what scientists are trained to do, which is to do something that's on the cutting edge so that you too can win a Nobel Prize. And if you actually go back and you look and you listen to some of what he said at the time, and even some of his writings, he thought that this would take him along that pathway. And he actually talks about Steptoe and Edwards and the first IVF baby. And he basically says, I'm willing to take that chance because he too was disregarded, criticized at the beginning, but eventually recognized for having pushed boundaries. So one of the things that I think is really important is to understand what he did and where he went. In the end, 3 of them are convicted. They have prison terms. They also have a $3 million fine, 3 years in jail. One of the things I started looking at in this context with colleagues of mine is to find out, at the time this happens, many people are looking to know, was it actually illegal in China for him to do what he did? And in the end, what he's convicted of is practicing medicine without a license because he created a pregnancy. And so what's interesting is where people went deciding that this is something that the society needed to respond to. And so colleagues and I then started to actually try to canvass countries around the world to find out what in fact was the law. This map is actually looking specifically now at germline genome editing, not for reproduction. So we're being very careful now with the language. And what you see is that some countries prohibit, but there are exceptions. Some countries permit, some it's really hard to know, but we do know that they actually have legislation. But when we're reading it, it's unclear which direction it goes in. Many countries have lots of policies that you would think would be about this and capture it. and they don't. And the countries that are not included are countries where we were unable to find any documents. This is for germline genome editing. What you see here is diversity. This is the map for heritable human genome editing. There's nothing in green. There's no country that explicitly permits this, and according to this, China prohibits it. China does, in fact, prohibit it now because after this event, they have rewritten laws to make sure that that is really clear. The United States is a complicated scenario, partly because of the ways in which constraints and research in this area are done through appropriation bills, et cetera. And if you look at the details in the paper, which I highly recommend, I think you'll find it quite interesting to see what's happening. Because what this says is the world is diverse, we're extremely heterogeneous, and yet right now, there doesn't seem to be a lot of heterogeneity about this issue, and there is distinction. So there are places that are willing to endorse research in this area, but not for reproduction. Work in this arena continues. Many reports are written. I'm not going to go into any of them in detail. I just wanted to alert you to the fact that there's continuing to be policy work in this space. The one of these projects that I did work on is the WHO report on the framework for governance. And that report, I think, is very important because it not only looks at heritable human genome editing, it also looks at somatic genome editing. And we have actually started a pilot project using the work on the somatic genome editing in Uganda. And so I think what's interesting is when you have intellectual work that you then are able to move out in practice into the real world and to see how that works. Very quickly, we have the third international summit. It took place in March of this year, and there you have the planning committee. And the interesting thing now, if you look at the statement, is it's shifted yet again, because we're now saying it remains unacceptable at this time. Public discussions and policy debates continue and are important for resolving whether this technology should be used, not when, but whether. And notice again at the end, societal discussion and policy debate has not been concluded. I think one of the things that's important to pay attention to is the overlapping membership and the shift. 2015, it would be irresponsible. 2017, a written report by NASA, it should be permitted. 2018, time to define a rigorous, responsible translational pathway forward. And now, 2023, public discussions and policy debates continue and are important for resolving whether this technology should be used. That's a very short period of time, and it's quite a bit of pendulum swing and difference. And I think what that says to us is how important it is to keep the conversation going. I now want to transition in the few minutes I have left to talk about somatic human genome editing. Why? Because we are actually on the cusp of doing this. So the stuff around germline and heritable genome editing is in some sense futuristic. Very important, I think, in terms, as I said before, of exercising the moral imagination and thinking about how much we want to invest in that area of science. But this is what we're actually going to be doing in our lifetime. And our lifetime means probably next year. It's been happening in clinical trials. We're anticipating it moving into the realm of therapy in 2024. So let me take you through those three statements again, but now looking at somatic human genome editing. I was part of 2015. I endorsed this statement, and basically, I came to believe afterwards that we basically gave somatic genome editing a pass. We basically said, hey, we know how to do this. We've done gene therapy for lots of years, and it can just be evaluated within existing and evolving regulatory frameworks. I'm not sure I actually believe that anymore. So one of the things that became interesting to me is that as I do work and my ideas shift, I go back to things. So in 2015, I said, I thought we know how to do this. It's great. We just do it like we do gene therapy. But then when I actually started looking at some of that work, I actually decided we didn't know how to do this and we didn't know how to do it well. And one of the reasons for that is we weren't paying attention to the usual rules between moving from the preclinical realm to the clinical realm. And in this paper, a colleague of mine who's a scientist and we actually describe that, what that's like. And the easiest way for me to show that to you is that in ethics, one of the things that's really important is that we keep that inferential gap between preclinical studies and phase 1 clinical trials as narrow as can be. And one of the things that's interesting is Mildred Cho makes the point, and she was a member of the committee that reviewed this work, that we need more animal studies. It was nonetheless approved. Well, one of the things that I did with my colleague is I actually looked at the sample size for the preclinical work. There were 3 different treatments, 17 animals. Only 5 animals were actually in the treatment group that moved into the human. And really, there was no random allocation, no blinding, nothing. I mean, this isn't how we do science. Now, you might turn around and say, well, we don't need to do preclinical studies at all because we can't draw any inferences. And there's a problem there in terms of translational research. But that's a very different argument than using the usual approach that we have to preclinical studies prior to moving to phase 1 trials. Now, that research went forward, et cetera. I'm just making the point that I came to believe that actually there are huge ethical issues here. And in 2015, we gave it a pass. In 2018, there's no assessment at all. There's really just a statement that acknowledges that this is being tested in patients. So really, we're just saying, yep, clinical trials are happening in the realm of somatic genome editing. And in 2023, because we know now we're on the cusp of doing this, one of the things that became really important is thinking about accessibility, affordability, and really recognizing that this would ultimately mean that we wouldn't really have a treatment. If you have an intervention that's going to be around the realm of something between $2 and $4 million, you don't have a treatment. At least not for those who bear the burden of the diseases we're going forward, which not right now, which many of them are orphan diseases, and those that are not, the burden of diseases in countries like Africa, where they are not going to be able to afford $2 million therapies. So one of the things that I think becomes really important here in terms of ethics is to think about issues of equity. This is an excerpt from that 2023 summit statement. As interventions based on somatic genome editing become more widespread, a commitment to equitable, financially sustainable, and accessible treatments becomes more urgent. That's where we're at right now. This is the urgent problem with respect to somatic genome editing. One of the things that's interesting is right after the meeting that took place in London, Antonio Regalado, who in fact is the person that helped to break the story in 2018 with Jean-Q Hay, actually now comes out and says, okay, in 2023, they're telling us, forget about those designer babies. Now what we really need to focus on is how this is potentially changing lives. The reason I put this up here is that our committee, the planning committee, has been criticized for having tried to take the lens off of something that would be clearly very important, heritable human genome editing, and trying to move away from that. And at some level, that's a fair criticism because that was in fact our intention. Our intention was to say we can't just spend all of our ethics energy on heritable human genome editing. We need to pay attention to the here and the now, and we actually have a huge ethical problem with respect to this. This is Victoria Gray. She actually spoke at the summit meeting, and she is one of the people who was a clinical trial participant, and she came to the meeting to talk about her supercells and to talk about what it was for her to have this illness and to experience that her whole life, and then to have the opportunity to participate in a clinical trial. But the interesting thing is she recognizes that that was an opportunity that will not be available to likely many in her community, because she didn't have to pay in the context of a clinical trial to get access. Just this past October, we actually had this reviewed by the FDA. The expectation is that it will be approved by December, and it will be on the market in 2024. And the interesting question then is, what's it going to cost? That work is done by Vertex and CRISPR Therapeutics. There's also another clinical trial. This is one of the patients here, LaChandra, with Bluebird, and it too is expected to come out, and it too is talking about a similar price tag for treatments for sickle cell disease. And so one of the things I want you to think about is, I think in this realm at the current time, what's critically important is obviously still safety and efficacy. but durability, affordability, and accessibility. And I've put up there for you what has happened in the last 5+ years. We have seen $1 million therapies come out, and the politics of those $1 million therapies are quite dramatic because, for example, in some cases, if they're not able to negotiate the prices they want, they actually withdraw the drug from the market. We've seen that. One of the cases is a drug Glybera that was developed in Canada, and it was never sold, or that's not true. It was sold once, and then it was given away several times, but it's basically no longer available because it's not seen to be cost effective if people won't actually buy it. We need to think about that, and we need to think about what are the ways in which we can manage that. And it's not a straightforward answer. Why? Because companies have obligations to their shareholders to maximize profit. Some of my work right now is asking people when in this capitalist world are we going to start to have a conversation about what's a decent profit? So I'm not imagining that we're going to dismantle capitalism, but I am asking in this realm, and more broadly in the realm of healthcare, it cannot be whatever the market will bear. It's not a context within which that makes sense. So now, I think as we're on the cusp of moving there, we're really going to see what this means to care when we're looking at $1 million interventions. I've said it before, but I just want to repeat it here. The burden of this illness is largely in Africa and other poor countries. It is a devastating disease. In those countries, children actually die before age 5, and so there's actually huge problems just in terms of diagnosis. There are alternative treatments available, but even those treatments are not available in those countries. And we need to really think about what are the implications for going ahead without thinking about the consequences for a broader community, a community that already doesn't even have access to standard of care. And the reason I want to emphasize this is that when people like myself in ethics bring this to the fore, the answer seems to be, well, we'll make sure that everybody gets access. And I'm thinking, you can't actually do that. You can't do that in the United States, but you also can't do that in my country, Canada, which has a government-funded healthcare system. It would be bankrupt, right? This isn't an option, and it isn't just for sickle cell disease. It's going to be for all kinds of illnesses going forward. We have a huge problem in terms of thinking through what it is, because I used to say governments are not in the business of printing money. Since the pandemic, I can't really say that anymore because we did get into the business of printing money. But by and large, you have a budget made up of taxes, and you're only going to spend so much of it on any one priority. Now, you might think that, healthcare is where it should be spent. Other people are going to think it's on the arts. Some people are going to think it's on arms. But I think the problem is you can't put 100% there. And this is what it would take up. It would take up all the budget. Now, NIH and the Gates Foundation have pledged $2 million, and it's a matching system. So NIH has put in 100 million, Gates has put in 100 million to investigate this issue of bringing gene therapies to patients who need it most. What that's going to look like, we don't know, because they too have the same kinds of dramatic problems and are busy trying to come up with creative scenarios. Industry is looking at it in terms of, do we not charge $2 million, but we spread the payments out over 4 or 5 years? Other people are looking about negotiating it in the context where certain parts of the world wouldn't be stymied in terms of having to pay the exorbitant costs, but that those costs could be carried by wealthier countries. I mean, there's all kinds of ideas being put out there, but the point I'm trying to make is what's important and different here is the challenges are not just scientific. The challenges are economic, and we need to think about those in tandem. Why? Because if you actually think that the goal is not just to have an intervention that works, but an intervention that is available and accessible to those who need it most, you may need to actually go back in terms of trial design. You may be needing to think about platform technologies in ways that you can actually offer things at a more reasonable cost that makes it possible to talk about this as a cure of some kind. So one of the things that's really important then is to appreciate the way the clinical pipeline works, and that basically, and these are not my words, we're about to discover what happens when the world's poorest patients may not be able to get access to the drugs that they need. And in closing, I'd like to share somebody else's words with you. This is a patient who passed away, and I'll just read the first part. When I was diagnosed as a sickler at age 10 years, the doctor told my parents there was little they could do. Later, we learned about hydroxyurea. Then we learned about bone marrow transplant. And now we're learning about gene therapy. The only thing more disheartening than being told you have a chronic disease that cannot be treated is being told you have a chronic disease for which there are cures available, but these treatments are not available to you. And with that, I'm going to end and entertain some questions. Thank you very much.
Thank you so much for that fascinating and nuanced talk, Dr. Bayliss. That was just wonderful. And as you say, we'll turn to questions now. So I just want to make sure that everyone who's listening recognizes that you should write their question in the chat, and then I can read them for Dr. Bayliss to be able to answer. So the first one we have here regarding the CRISPR trial. The ability to conduct a clinical trial in the US is based on assessments by the FDA. The agency makes a decision about allowing a clinical trial to move forward based in part on preclinical research. What do you think FDA needs to do differently in its review process to address Dr. Cho's critique?
Well, I think we actually need to make a principled decision about whether or not we think we need to do preclinical work. And if so, then we need to hold the scientific community to that. And I think the problem and the tension here is that when you have something promising, you think about it in terms of a benefit, and you think about that benefit being withheld through unnecessary time delays doing more research in a particular animal model. But I think, and I've done some work around this with colleagues in not just this area, but in areas of neurotechnology, really asking questions about, do we have the right animal model? Do we have the right number of animals? Do we have the right amount of time invested in that preclinical work? And I think that those are questions we should be careful to answer in advance of making those kinds of decisions. And I don't think it should be done in an ad hoc kind of way. So I think it's complicated, but I think there's a principle behind that. And the principle is, in theory, you're trying to put the least amount of humans at risk. A really, really important thing to remember in the context of clinical trials is it could go very badly. People often think about clinical trials as getting access to the latest, greatest technology. And that's part of what we refer to in bioethics as the therapeutic misconception. You actually think you're getting access to a therapy. You are not. You're getting access to an opportunity to contribute to knowledge production. And part of the moral obligation of the scientific community is to be able to assure the FDA and others, including the patient, that we have done everything we can to anticipate what the possible harms are and to minimize those. But we can't say it's zero. And in fact, we may know that there are particular risks, and we will hopefully disclose those to you in a way that you can take that into consideration. But you are inviting a patient on a particular path with you to contribute to knowledge production and the making of a better world for everyone. And along the way, they may benefit, but they may not. And so in that context, I think it's critically important that we have clear standards and expectations, and to be sure then that they are met. And that responsibility does belong to the FDA in this context.
Thank you so much. Steve, I'm going to maybe come back to your second question and then perhaps ask Malcolm's question first. Perhaps, Dr. Bayliss, you can discuss the harms that prematurely considering the cost of novel therapies does in slowing research when history predicts that the costs can be expected to come down as technology advances.
So one of the chapters in my book is actually called Slow Science. And in there, I try to discuss this concept and this understanding to say to it, what is it that we're ultimately committed to? And I think one of the things that we are at risk of doing in some cases is just getting really excited about really cool technology. And let me assure you, CRISPR is really cool technology. And we've seen, the ways in which it can have an impact in many other arenas, including, for example, the development of vaccines in the pandemic. So I'm not advocating for let's go slow for, the sake of going slow. But what I am advocating for is slowness so that we actually do better work. I will say to you, my experience as somebody who writes and publishes is that we live in a world right now where scientists work to meet certain metrics of success. Salami publishing, quite frankly, prematurely. I'm not even going to talk about fraud, but there's so many things that we do to respond to incentives that are actually the wrong incentive. And if the incentive is knowledge production and making the world a better place, maybe we need to go slower. Why? So that we actually ask a better question. And if you ask a better question, you'll hopefully get a better answer. And too often I would say to you, I have seen science projects where it wasn't a really good question. Why were you even asking this? Or ultimately, you're actually asking a question that's already been asked and answered. And sometimes it takes time to do that. And I would say to you, there's not enough time left for critical reflection and trial design. I am deeply committed to robust trial design. I write and talk about both scientific validity, but scientific value. And scientific value is getting the right question so that you're actually going to then be able to generate a solid answer to something that we need to know. So it's not slow down just for the sake of going slow. It's more along the lines, and I use this example of think about the slow food movement. It's not about saying, well, you're going to eat at midnight tonight. It's about saying there are better ways of growing our food such that it's more nutritious, such that when we eat at the right time, it's actually healthier for us. And it's that kind of idea. Can we actually stop and think carefully about the priorities and how we're going to meet them? So, for example, in the area of somatic genome editing, we would take time to figure out when I look at sickle cell disease and I look at the burden around the world, where do we need these interventions? These places don't even have access to the things we already know about, like hydroxyurea, like bone marrow transplantation, like even diagnosis so that we can find those who might benefit. And so it's in that context that I want to say the questions are complicated and we need to create space for people to reflect. And my experience is we have taken away a lot of that space.
Thanks. And then from Stuart Finder, we have at all 3 international summits, there's been calls for public disclosure. And certainly over the past 4 to 5 years, social disclosure about complex, let alone controversial issues has become more challenging. How do you envision such disclosure being pursued at this point?
So one of the things that I champion in my work, and I'm pleased to say is in the WHO report. So one of the things that's interesting is that, and I'll say this as a quick aside, whenever you read any policy document, and that's because that's one of the themes, you should pay attention to the authors, because you should go back and then see how their work has or has not made it into a document and influenced it. And that's not in terms of, taking credit for something. It's to say, very often you will see 3 or 4 different policy documents and they all say the same thing. And then people will say, oh, this must be the truth because look, they say this in the Netherlands, they say this in the US, they say this in Canada, they say this in France. And you want to say, wait a sec, go look at the authors. It's the same people, right? So, it's really important to pay attention to authorship for all kinds of reasons. But in this space, one of the things that I've argued for independently as an academic, and I have been advocating for this in a number of policy arenas, and I'm genuinely pleased to see the uptake, is to say that we need to think about this in the realm of education, engagement, and empowerment. What I say and what I believe is that we understand public education is important, but too often that is based on the knowledge deficit model, and that is not the way to think about public education. And I still hear people saying things like, oh, if only they understood the science, they would believe me, and of course they would follow me because. And so what you're doing in that context is you're assuming that people are not on side because they're too stupid to understand. And that's not the case. They may just have very different values and starting points. They may not be able to articulate them clearly, but it doesn't have to be that the only explanation is stupidity. We understand and we are committed to doing education. We just don't always do it as well as we could, but we are committed to that. Recently, we've seen a shift, and recent means the last 10 to 15 years, we've seen a shift towards public engagement. And there you'll see things like citizen juries or surveys or polls, or, they'll do really creative things like we'll put on a play and then we'll have an audience participation and discussion. So there's lots of work creatively trying to engage the public and get them to really have deep, meaningful conversation. And they'll do this sometimes, with experts available to provide answers to questions and to nurture a certain kind of understanding. The third part, which is what I've been pushing for and which I think is important, is empowerment. And empowerment there is meant to do things like capture citizen science. Empowerment is meant to say allowing people other than the bona fide scientific community to actually influence the research agenda. And when I say others, it might be politicians, it might be civil society, but it's to say that if there's no possibility for anyone to actually influence what are seen to be the research priorities, then the rest of it's just a game, right? It's a facade. I'll talk to you, I'll listen to your ideas, I'll educate you, but No, 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 no. You can't have any impact on what we're going to do. This is all about us just talking to you nicely, right? We want to hear your ideas. And I actually think at the end of the day, that's disrespectful. I'm committed to consensus building, and I will say to you, if you come into the room and you know you're the smartest person in the room and you're not listening to anybody, what's the point of being there? And I will tell you, people like myself as philosophers, I could go into a room and I could spend hours, days with people, and I could have them reach a conclusion and have them believe that they reached that conclusion all by themselves and have completely manipulated and played a game. That's not what this is about. One of the elements I write about in consensus building is respect. You have to respect people and their ideas, and you have to believe that you just may not be the smartest person in the room. And that means you could learn from somebody. They might say something that would have you shift, maybe even just a little bit. But that's what knowledge production is about. It's an openness to the possibility that there's something you could learn. So that in a nutshell is kind of the way I think about that issue.
So I'm very conscious, unfortunately, that our time has elapsed, Dr. Bayliss. Can I thank you most sincerely for such a contentful and reflective presentation? There was so much there to think about, and you really helped us think about it. Thank you also. It's so refreshing, even if we might not agree with your conclusions, to encounter a thinker who is prepared to put their commitments on record rather than simply enumerate possibilities. So on behalf of the Ethics Centre, on behalf of Tom and Leslie and of the audience and of the UCLA community, thank you so much for giving the 2023 Weinberger Vermut genetic ethics lecture. And I only hope that at some point we can have you here in person, so that we can show you the California sun, rather than what I assume is a rather dreich, as I said before, Canadian winter. So thank you again. And
well,
thank you.
No, I just wanted to turn around and say thank you again in a very sincere way. I do appreciate being given an opportunity to share my ideas. And I hope some of it has been enough to spur people to go on and think a little bit more about it and to turn these into conversations around dinner tables, because that's about spreading the word.
Okay, thank you. So thank you again, and to all our friends and supporters of the Ethics Centre, thank you for attending the lecture this year. Have a great day.
Thank you.